Okay, good morning again. I think we can get started. I will invite my panel members shortly. Let me introduce myself first. My name is Dr. Hande Harmancı. I'm the WHO representative in Azerbaijan. The reason that I am in this global meeting is we are getting ready for our first EMTs in Azerbaijan with the Ministry of Emergency Situations and, of course, other ministries of relevance like Ministry of Health. This session is about financing. It's about money. And I will tell you our aim by this session. As we all know, EMTs require investment, including capital investment in equipment for human resources, like salaries, for warehousing, equipment maintenance, etc. This session aims to share examples and experiences from around the world, looking at how EMTs, particularly teams that are not from high-income countries and high-resource settings, they have leveraged national budgets, partner support, and other innovative approaches to develop EMTs. Our hope is that this session will inspire governments, NGOs, donors, partners, and others to find new ways of enabling the development of robust national and international EMTs, adopting and adapting global principles and standards to ensure all the countries have the capacity to manage health emergency response and that global and national capacities are in place and can be leveraged when needed. So to talk about this very important session, I have distinguished panel members whom I will now invite to the panel by one, reading their short bios. We have Dr. Nahom Tadele. Please come to the stage, Dr. Nahom. Dr. Nahom is a senior disaster medicine expert with a robust background in disaster management. As the lead for Ethiopia's emergency medical team, he has advanced and overseen the implementation of the Ethiopian EMT initiative in collaboration with WHO. Welcome and good morning. Next, we have James Marsh, who is a policy advisor in the Humanitarian and Disaster Management Unit within New Zealand's Ministry of Foreign Affairs and Trade. James supports New Zealand's responses to humanitarian crises in Asia, Africa, and Europe, and is also responsible for the foreign affairs aspects of humanitarian health responses and preparedness in the Pacific. So we have a global health diplomat. Welcome, James. Good morning. Next, we have David Towns. Dr. David is a senior health advisor at the Bureau for Humanitarian Assistance at the USAID. He's a professor of emergency medicine and global health at the University of Washington in Seattle, Washington, and a former lieutenant commander at the United States Public Health Service. Thank you and welcome. Thanks for being here with us. Next speaker is Bernadette Pua Velasco. Dr. Bernadette is an emergency medicine physician. She's a director at the Health Emergency Management Bureau and an operations manager at the National Patient Navigation and Referral Center. He's also an executive committee member on the Pan-Asian Resuscitation Outcome Study. Welcome. Good morning, Bernadette. And we have Diego Orlando Pozo, who's a technologist in pre-hospital care, specialist in trauma and anesthesiology with more than 30 years of experience in emergency management, coordination of pre-hospital care groups in Milan, Italy. He's a firefighter. I was very impressed by that, and extensive management in emergencies and disasters. He has been working for 19 years in the field of international cooperation, leading projects aimed at the hospital and firefighting sector. Good morning. Thank you for being with us. What we will do is we will have short presentations from the panel members, and then hopefully we will have time for Q&As, because I'm sure there's going to be a lot of interest in financing EMTs. So with that, I want to invite Dr. Nahom Tadele to make his intervention. Here is the thing to use.
So thank you very much for the opportunity and for the introduction. So I'll be presenting on sustainable financing for Ethiopian National Emergency Medical Team Strategic Plan. So for those of you who are not familiar with the country, Ethiopia is a landlocked, ancient, rich with cultural heritage country, home of warm and welcoming people with a deep-rooted tradition, diverse landscape. As you can see in the map, we have highlands, we have lowlands, depression below sea level, with active volcano, historical landmarks located in East Africa. So context of Ethiopian health emergency, geographical and climate vulnerability is still there. We have large parts of the country prone for drought and flooding, and also other natural disasters, significantly areas receiving minimal annual rainfall. We have also public health challenges, disease outbreak still being our problem, AWD, malaria, COVID, measles still exist in the large parts of the country. Food insecurity also triggers malnutrition affecting millions. Humanitarian and conflict-related emergencies also are reality. So the Ethiopian EMT provides rapid, effective medical care during emergencies. For the last 5 years, we are trying to implement the initiative in our system. We have extensive experience in responding for multiple emergencies within our country. So alignment with the health policy of our country, the EMT initiative strategies aligned with the Ethiopian health policy, support the national goal for accessible, equitable, and quality health care. The strategy aligns with priority for strengthening emergency health care and crisis response. The Ethiopian EMT strategy is also aligned with the Ethiopian Public Health Institute strategy, focus on building responsive and sustainable health system. It's also aligned with WHO 2030 strategy, providing global standards, emergency response preparedness, and rapid deployment. So sustainable financing strategy, the importance of diversifying funding model, reduce reliance on any single source, ensuring sustainability. That's our motto. So potential financing sources, we identified 4 potential sources. The first one being government. The core financing components demonstrates commitment. We have, for the first time in our government system, we have secured sustainable amount of budget for the implementation of the EMT. So we are using from the government budget. Also, the other area of finance is donation, collaboration with partners and other potential donors, leverage external funds using other organizations also as implementing partner. We are successful also on mobilizing donation. Private sector, engage in private companies in logistics and technology development is also one of the strategy. Innovation using public-private partnership, social impact bond, and health insurance being also one of the potential sources. So resource mobilization, comprehensive resource mobilization strategies still exist, outline the fund needed, priority setting, and potential source need to be identified, and we are working on that aspect also. Relationship building, engage with donors, partners, emphasizing the EMT impact. So we're using the partner forum, such conferences as a platform to leverage, to show what the Ethiopian EMT is aiming to conduct and what we are working on currently. Joint funding proposals, still we are using different mechanisms. For example, recently, along with WHO and FAO, we submitted a proposal to pandemic fund, and we secured sustainable amount of money on capacity building activity that will be used for capacity building activities. So, ensuring sustainable financing, the financial management needs to be transparent, accountable system needs to be in place, efficient resource utilization needs to be designed, monitoring and evaluation, track the progress, measure the impacts, identify improvement, and persistent updates for the partners, donors, and the government officials is also one of our key activity. So long-term sustainable plan strategies for diversifying the fund, building local capacity, reducing external reliance is one of the long-term strategy. Regular reviews and updates, adapt financial plans to change needs and circumstances. Conclusion, the key takeover, sustainable financing is critical for the resilience of Ethiopian EMT. The outcome is diversified fund models, robust financial practice, and long-term planning will ensure Ethiopian EMT capability to respond effectively to healthcare emergencies. So, thank you. This is my presentation.
Thank you very much. Thank you very much, Dr. Nahum, for this sweet and to-the-point presentation. In my list, I have Dr. Diego Pozo for the next speaker. Are you ready for your presentation, sir? Please. I believe Dr. Pozo will speak in a language other than English, so if you have your headsets, please use them now.
Hola, buenos días a todos. Muchas gracias por este espacio. Gracias sobre todo por permitirnos contar una realidad de Colombia y nuestro proyecto del Barco Hospital San Rafael. Los invito a ver este corto video.
The Pacific coast of Colombia, a region that over 300,000 people call home. There are no roads here, no cities, and for most inhabitants, there is nowhere to go for health care. However, today, one special hospital floats past all the barriers to reach her patients in need, the hospital boat San Rafael.
Bienvenidos a todos. Estamos en 92 centímetros. Muy bien, lindo eres.
Mantengo sola, porque como no me puedo colocar los zapatos, entonces necesito colocar algo.
Tiene la presión muy alta, ¿yo? Muy alta. Sí, señora, es que tiene que tomarse el medicamento oficiosita para que no se le suba mucho la presión.
Alerta.
On board the hospital boat San Rafael are over 20 volunteer doctors and skilled nurses. Women and children patients are seen first, but nobody is turned away. Over 300 patients are treated in a single day, and for many of those, this will be their first time ever seeing a physician. The hospital is equipped with a pathology lab, consultation bays, an operating room, a pharmacy, and pediatric and gynecology departments. Our mission is to provide culturally sensitive and compassionate medical care to the entire Pacific region of Colombia.
Llegó un paciente herido de bala.
Necesito unos líquidos. ¿Con qué se hirió?
Machete.
Ok. Mueve los dedos. Metámoslo al quirófano, le damos un lavadito y le suturamos. México es una adolescente de 15 años que ingresa al barco hospital a un control prenatal. Nunca ha hecho un control prenatal, nunca ha ido a un médico. Nuestro ginecólogo la visita y encuentra que no hay líquido amniótico y por eso se procede, que es una urgencia, llevarla a hacer un parto de urgencia.
The small but mighty hospital boat San Rafael will continue to overcome geographic, economic, and political barriers to reach her patients. Because if she won't, nobody else will. Our work prevents these neglected communities from seeing their suffering as natural and, for lack of resources, resigning themselves to illness and death. Please join us on our mission to bring everybody on board.
Ok, entonces ahora arrancamos con la presentación, por favor. Pues ya pudieron ver el contexto de lo que trabajamos nosotros. Es un barco hospital que recorre el Pacífico colombiano, pero también tenemos un hospital móvil que es un EMT tipo 1 fijo, recientemente certificado por la OMS. Y lo que me corresponde hablar a mí es de cómo financiamos, porque no somos del Estado, no tenemos un presupuesto fijo cada año, sino que tenemos que rebuscarnos y trabajar día a día para buscar los recursos para llevar salud de excelencia, como lo llamamos nosotros, a estas comunidades. ¿Quiénes somos? Una organización privada, una ONG creada en el 2007 para Colombia. Tenemos unos orígenes italianos, pero en el año 2010 cortamos el cordón umbilical con Italia y ya comenzamos a navegar solitos nosotros. Prestamos servicio de atención médica a través de un barco hospital y ahorita nuestro nuevo hijo es el EMT Barco Hospital, donde queremos llevar salud de excelencia a través del territorio colombiano, sea vía terrestre o vía aérea o donde sean necesarios. Trabajamos con poblaciones vulnerables. Esta costa del Pacífico son más de 1.300 kilómetros de costa, donde en el año 2016 se firmó un convenio, un acuerdo de paz, pero lo que hizo fue atomizar la guerra, atomizar el problema de la seguridad en esas zonas, y antes era un solo grupo, ahora son muchos grupos que dominan la costa. Somos respetados, somos queridos por lo que hacemos, por nuestra misión de llevar salud de excelencia a esas comunidades. Todos los grupos nos respetan y nos permiten ingresar para poder llevar salud a estas poblaciones. Tenemos una componente que es etnocultural, trabajamos tanto con las comunidades indígenas como con las comunidades afro y lo que hacemos es llegar a acuerdos con ellos para también tratarlos con medicina ancestral y medicina occidental. Entonces hay un acuerdo. Nuestros médicos son capacitados antes de cualquier misión para que tengan la jerga, la forma de que hablan las comunidades y así no pueden romper ese hielo que causan muchas veces las barreras de comunicación entre médicos y pacientes. Y algo muy importante, hasta más del 80% de nuestros recursos que recaudamos a nivel nacional o a nivel internacional son dedicados a la operación pura de la nave hospital y de todos nuestros proyectos. ¿Qué hacemos? A través de un modelo de atención con enfoque etnocultural, es que lo cual les comentaba ahorita, tratamos de llevar una salud adaptada a los contextos sociales, culturales y territoriales del territorio de la costa pacífico colombiana. ¿Cómo lo hacemos? Pues a través de unidades móviles, acuáticas, equipos de salud. Cuando el barco no puede ingresar, también lo hacemos en lanchas pequeñas que podemos ir a grandes territorios de distancia más lejos. Y ahorita con el EMT brindamos servicios de atención humanizada con calidad en consulta médica general, especializada como pediatría, ginecología, medicina familiar, laboratorio nivel 1 y 2, toma de muestras laboratorios, consultas, procedimientos odontológicos, ecografías, tanto obstétricas como ginecológicas, atención mental, cirugía ambulatorial de nivel 1, respuesta ante emergencia y desastres y educación en salud pública. Fuentes de financiamiento, pues los EMT se financian de diversas maneras, dependiendo de los países y de la estructura. del sistema de salud. Algunas fuentes de financiamiento podemos decir que son financiamientos por los gobiernos, que son la mayor parte que están aquí, son EMT del Estado, y nosotros que somos EMT, que somos de ONG o instituciones privadas que queremos servir, apoyar y fortalecer los esfuerzos de los gobiernos. Pues yo no quiero entrar a hablar de cómo es el financiamiento de los gobiernos, porque creo que ya más de uno de ustedes saben cómo se financian o cómo buscan los recursos para poder mantener y para poder operar los EMT a nivel gubernamental. Entonces, pues quiero solamente decirle que en Colombia existe una figura que es la Unidad Nacional de Gestión del Riesgo y Desastres, y lo que se quiere o lo que se espera es de que cuando suceda una gran emergencia, a través de esta unidad, de esta dependencia que hace parte de la Presidencia de la República, podamos recibir recursos económicos para la activación y operación del EMT, tanto en Colombia como a nivel nacional, como lo fue hace 2 años cuando el terremoto de Turquía y el gobierno nos pidió de apoyarlos en Turquía. Bueno, no fuimos, ¿no? Al último, todo en el avión, esa foto que está allí es del avión, no pudimos ir, pero pues la intención del ejercicio se hizo. Y los EMT privados o la ONG, como en el caso de nosotros, pues hacemos programas de fundraising y hablamos de captación de recursos en algunas organizaciones no gubernamentales o ONG, presentamos proyectos a instituciones internacionales, en el caso nuestro como la Unión Europea, que prácticamente el 75% de nuestros recursos provienen de la Unión Europea hace 6 años, pero fue difícil llegar allí, fue difícil convencerlos de que apoyaran un proyecto de ese tipo, y ahora estamos en la consecución de recursos para la implementación y funcionamiento de nuestro EMT, porque pues está recién, nació hace poquito, hace mes y medio nació, hace 3 días nos certificaron oficialmente, entonces ahora estamos en la consecución de recursos para poder operar. Algunos EMT pueden hacer convenios en la parte nuestra con las IPS o con las empresas, las aseguradoras, ya, o algunos estados, algunas instituciones, lo que les hablaba anteriormente, de hacer acuerdos con instituciones del Estado que te pueden financiar o te pueden contratar o pueden comprar paquetes de actividad para la atención de emergencias. Y programas de formación, recibir financiamiento a través de programas de formación y entrenamiento, intercambio de conocimientos entre diferentes instituciones. Lo que hablábamos anteriormente, los EMT, pues tenemos todo también la parte de crowdfunding, utilización de plataformas virtuales y hacer recolección de fondos. Estamos entrando en este campo nosotros, no somos muy expertos, pero estamos rodeándonos de un grupo de voluntarios, un grupo de asesores para entrar en este medio de crowdfunding y poder recaudar donaciones y aportes para buscar colaboraciones estratégicas, formales con gobernaciones, alcaldías y con el ministerio. Y aprovecho que está aquí el doctor Picón del Ministerio de Salud de Colombia, que me acompaña en esta sección, porque se están haciendo alianzas con ellos, porque somos el primer EMT en Colombia certificado que puede darle ese tipo de soporte y respaldo al gobierno colombiano. Recientemente tuvimos la oportunidad de colaborar con la COP16, donde la organización y las Naciones Unidas pidieron que nuestro EMT recién certificado fuera el que prestara la atención médica en la COP. Se atendieron más de 650 pacientes dentro de la zona de negociación de la COP y digamos casi a 850 pacientes en todo donde estamos nosotros desplegados con 3 puntos. Entonces, pues es algo muy importante. Y marketing y concientización, pues es lo que estamos haciendo, es lo que hacemos día a día, buscando nuevos aliados estratégicos a nivel nacional e internacional y la cooperación internacional. Nosotros contamos con recursos de ECO, de BHA, o sea, BHA, y bueno, estamos trabajando con USAID y otras instituciones o fundaciones privadas que nos permiten recibir fondos como Medicare, Médicos del Mundo, y entre otras, APS de España y otras fundaciones que conocen nuestro trabajo y estamos haciendo alianzas para fortalecernos. Y yo no quiero tomarme más del tiempo porque ya estoy a 10 segundos, solamente decirles gracias a ustedes por permitirnos contarle esta realidad, lo que hacemos por Colombia, lo que hacemos por la región, pero sobre todo lo que hacemos por una comunidad que tanto lo necesita. Muchas gracias a todos.
Thank you. Thank you very much. This is very, very interesting for me. Yeah, I have never seen an EMT like this. I think you will have a lot of questions from the audience. Next, we have Dr. Bernadette Velasco, who will describe the financing of the three WHO classified EMTs in the Philippines, known as Philippine Emergency Medical Assistance Teams.
Good morning
Dr.
to
Ben.
everyone. So this will be the outline of my presentation or discussion. So I'll be explaining what the Philippines is and why is it important that we invest on our disaster response. And also after which, I'll discuss on some of the issuance and funding sources, how we created or established the emergency medical team. So again, the Philippine archipelago is characterized by biodiversity and geographically located in the Pacific Ocean. We have three major islands, Luzon, Visayas, and Mindanao. So imagine our country being separated by water. We have around 7,600 islands, so it makes it more complicated on how do we respond in terms of disaster. So this infrastructure development and even the interregional communication network is really very challenging. And also for 16 consecutive years, according to the World Risk Index, we have been globally at the first or most at-risk country globally. On May of 2010, Republic Act 10121, or the Philippine Disaster Risk Reduction Management Act, was signed into a law and paved way to the adoption of the disaster risk reduction management approach that is very holistic, comprehensive, and also proactive in lessening the socio-economic impact and also environmental impact of disasters, including climate change, and promote the involvement of the whole society. This RA 10121 contains the NDRRM framework, or National Disaster Risk Reduction Management Framework, which provides a comprehensive, all hazards, multi-sectoral, inter-agency approach to DRR. It also serves as a principal guide to disaster risk reduction and management efforts to the country. This framework envisioned the country to be safer, adaptive, and disaster-resilient Filipinos towards sustainable development. And it also conveys a paradigm shift from reactive to proactive in our approaches in disaster risk reduction management. So the NDRRMC is a working group of various government agencies. Shown in this slides are the various organizations or offices inside the national government of the Philippines. The council is administered by the Office of the Civil Defense and is responsible for ensuring and the protection and welfare of the people during disasters or emergencies. This slide zero in the health cluster, wherein the Department of Health is the lead through the health, also through the Health Emergency Management Bureau. So I'll go now to the source of fund. Since the three PMATs are within the government, and we were able to tap a lot of funding sources. This is just to mention 4 of them. Hospital and regional offices, the Health Emergency Management Bureau, Office of Civil Defense, and also the Quick Response Fund. Not in this slide, the 5th one are from our partners. To mention also, our PMAT is health facility based, so we were also able to tap the respective hospital or health facility and even the region's existing fund and income. Through the Health Emergency Management Bureau, who serves as the primary coordinating unit within the Department of Health for all health and health-related emergencies and disaster, and also as the lead of the health cluster, we oversee the areas including the medical services like WASH, MHPSS, and also nutrition. So during the establishment of the 3 PMATs, HEMB provided essential financial support through sub-allotment of funds, facilitating procurement of equipment and capacity building on the pool of EMTs. Yearly, we are sub-allotting funds for PMAT so that their capacity will be enhanced and also improving. Through also the HEMB, the DOH has provided a comprehensive approach in supporting the 3 PMATs, utilizing the preparedness cycle. So carefully planning throughout the years, conceptualizing and building up the competency of our PMATs, organizing, ensuring adequate number or personnel, and equipage have been supported by the provision of sub-allotment of funds. Exercises and also real in-country deployments of PMATs even before verification have also been supported to enhance their capacity and experiences. So now let's go to the Quick Response Fund. So every year we are given by the government around $10 million so that we will have a standby fund for the purchase of supplies and services for relief programs and services for relief programs and projects, including response and recovery and rehabilitation requirements. In order that the situation and living condition in communities or areas stricken by disasters and complex emergency may be normalized as quick as possible. So this provision of Quick Response Fund is one mechanism that allows the availability of fund for emergency purchase of goods and services and for response and rehabilitation program. So it also includes procurement of logistics and also payment of other services like logistics management and also traveling expenses and even accommodation of our health emergency response team and also PMAT. Aside from the 2 that I mentioned, the Office of Civil Defense has as the implementing arm of the National Disaster Risk Reduction Management Council shall have the primary mission of administering comprehensive national civil defense and disaster risk reduction and management by providing leadership in continuous development of strategic and systematic approach as well as measures to reduce the vulnerabilities and risks of hazards and manage the consequences of disaster. The Office of Civil Defense provides fund to support transportation of our Philippine Emergency Medical Assistance Team, including its logistics as lead of the logistic cluster, as I presented a while ago in the slide. As the Secretariat of NDRRMC, the OCD could facilitate access to other resources and support from partners. Lastly, other fund sources, aside from the 4 that I mentioned, are the partners. So health sector partners like WHO and UNICEF have been helping us establish the Philippine Emergency Medical Assistance Team. The local government has also a role wherein respective hospital is located. They also invested on this. And also from the PMAT mentors itself, they also shoulder some of the expenses in establishing the Philippine Emergency Medical Assistance Team. So basically, to conclude, we have 5 sources of funding in the establishment of our the 3 Philippine Emergency Medical Assistance Teams. So first is the hospital and region where the hospital or the PMAT is located. Second is the sub-allotment from the Health Emergency Management Bureau. Third will be from the Office of the Civil Defense. And lastly is the Quick Response Fund. This is the standby fund for any response operation and rehabilitation. And lastly, from our partners. So that will be it. And good morning to everyone.
Thank you. Very much. Thank you very much for your presentation. Now we have Mr. James Marsh, who will describe how New Zealand's Ministry of Foreign Affairs and Trade, through a multi-year investment and partnership with WHO, worked in 6 South Pacific, has supported the EMTs in the Pacific. Thank you.
Assalamu alaikum, kia ora koutou, hello. My name is James Marsh, and I've been asked to briefly present on New Zealand's partnership with the WHO's Western Pacific Regional Office to support the development of emergency medical teams in the Pacific. In New Zealand's case, humanitarian responses offshore are led by our Ministry of Foreign Affairs and Trade, and we draw on a range of government and non-government partners to prepare for and to respond to emergencies. As part of this, we work with a number of partners, including the WHO's Western Pacific Regional Office, to strengthen public health emergency responses in the Pacific. So, Pacific EMTs, where are they? For those unfamiliar with the Pacific, let's take a moment to situate ourselves. In terms of large land masses, we're looking north and eastwards of Australia, with New Zealand not appearing on this map, being around 2,000 kilometres or a 3-hour flight south of Fiji. Nearly every country in the Western Pacific has developed EMT capacity or is working to develop national teams. Pictured here are 13 national EMTs, noting the wider Western Pacific region now has 16 classified international EMTs that can deploy to support emergency responses in other countries when requested. And congratulations to the Philippines. So what has New Zealand committed in this space? We're currently in phase 2 of our partnership with the WHO's Western Pacific Regional Office. This is a space that New Zealand co-invests in alongside the Government of Australia and others to support stronger EMTs in the Western Pacific region. It's a financial commitment, but it's also a commitment to supporting the program through our own EMT, NZMAT. The initiative seeks to develop and strengthen EMTs in 6 Pacific countries. Those are Fiji, Samoa, Tonga, Vanuatu, the Solomon Islands, and the Cook Islands, to be able to rapidly deploy trained, equipped, and self-sufficient clinical and public health teams in response to health emergencies. These teams are mostly focused on domestic responses in countries made up of dozens or hundreds of islands, highlighting the importance of mobile or deployable capabilities being able to reach the most remote of settings. The initiative seeks to support those EMTs to maintain high deployment readiness and has enabled the purchasing, kitting, and maintaining of cache for rapid deployment, in addition to strengthening capacities, SOPs, and policies for deployment of national EMTs, and supporting a coordinated regional approach to EMT development through global and regional trainings, including by developing a pool of EMT experts and coordination of regional EMT governance. So why does New Zealand make this investment? New Zealand is committed to a stable and prosperous Pacific and prioritizes supporting partner governments and other humanitarian actors in the Pacific to prepare for and to lead inclusive and effective humanitarian responses. This reflects that we are a part of the Pacific neighborhood, which is our geographic focus for supporting disaster preparedness and response. Our investments in the humanitarian space are guided by our humanitarian action policy, which is itself guided by the overarching humanitarian imperative: to save lives, to reduce suffering, and to uphold the right to life with dignity, responding quickly to major threats to limit humanitarian consequences. Pacific Island countries, including New Zealand, are at a high risk of sudden onset disasters, heightened due to the increasing impacts of climate change and the risk of emerging disease threats. For us, supporting the capacity of Pacific EMTs is a useful means of assisting partner governments to ensure that significant health emergencies are effectively responded to through national or international EMT deployment. New Zealand won't necessarily always be able to deploy, or be able to deploy quickly enough to provide life-saving assistance in every case. This program supports localized capabilities for more appropriate, faster, and more agile responses. New Zealand, as a Pacific country, is also not immune to emergencies. Following Cyclone Gabrielle, for example, Fiji and Niue supported the New Zealand response and recovery. We see building Pacific response and resilience as a mutually beneficial resource for the region. So a little bit more detail on how we've worked with the WHO. New Zealand has worked in partnership with the WHO's WPRO since 2018 to deliver the Pacific EMT initiative. We're grateful to the WHO, to Australia, and to each of the Pacific partner governments for their consultative, collaborative approach in making Pacific EMTs a reality, enabling our region to support itself and to support others during health emergencies. In addition to funding, New Zealand, through its own EMT, NZMAT, supports regional EMT capacity sharing by providing technical support and expertise as part of WHO EMT trainings on topics such as optimization of cache contents and specialized logistics planning, pharmaceutical cache planning, planning and outfitting of EMTs to deploy by means such as boat or aircraft, clinical operations in the Pacific, and matters of general coordination. As New Zealand, we also benefit from mutual capacity sharing. The program allows for a two-way exchange of knowledge, supporting NZMAT and New Zealand to understand the challenges and protocols across different countries in the Pacific and to share or receive resolutions that NZMAT or others may have found in their experiences. This is all about being part of a wider EMT family. So on to the outcomes of the program so far. From a New Zealand perspective, this has been a great initiative to support, with significant progress having been made across Pacific EMTs in 5 countries since 2018, and the program since having expanded to include the Cook Islands and Cookie-Mat in Phase 2. Key highlights include WHO support for national EMT development across Fiji, Samoa, the Solomon Islands, Tonga, Vanuatu, and the Cook Islands through tailored technical support, bespoke Pacific EMT cache, and supporting nationally led training. Other highlights include EMTs being operational and becoming essential components of national health emergency responses, FEMAT's International Type 1 Fix classification, and 2 international deployments to Tuvalu as part of its COVID-19 response, and Vanuatu following tropical cyclones Kevin and Judy, and domestic deployments by FEMAT, VANMAT, SOLMAT, and TMAT. Also, a recent highlight, and pictured on this slide here, was the deployment of 26 NZMAT personnel to work with 45 Samoan medical staff at the Chogum Medical Ward, with an additional 4,000 people meeting in Apia last month for the Commonwealth Heads of Government meeting. So what? We share the view that the capacity of governments to detect and respond to health emergencies and outbreaks within their borders and to call upon and coordinate appropriate international assistance in a timely manner are key components of a strong health system and pillars of the international health regulations. We think the WHO EMT initiative is a critical means of supporting that mission and has found success in the Pacific, supporting the capacity of Pacific Island countries to respond to emergencies both nationally and regionally, meaning that Pacific governments and people affected by emergencies can expect predictable and timely responses by well-trained, well-equipped, and self-sufficient EMTs. We think the initiative can serve as a model for EMT collaboration with demonstrated real-world outcomes, and hope that its successes can be applied also to other contexts and other regions. Thank you.
Thank you very much, New Zealand, for supporting EMTs and for working with WHO in the Western Pacific region. And our last speaker is from USAID, Dr. David Towns, who will present their collaboration with WHO, again in the Pacific, to support national EMT development in some of the most remote and challenging geographical settings. Thank you.
Thank you. Good morning. My name is David Townsend. I'm a health advisor for USAID in the Bureau of Humanitarian Assistance, and I'd want to talk about our support of EMTs. I wanted to start with a little bit of history and historical perspective. At the time, it was the Office of Foreign Disaster Assistance, which many of you know has now sort of grown into the Bureau of Humanitarian Assistance, but essentially a continuation of the same part of USAID. And I think our first involvement in the EMT initiative, which was the Foreign Medical Team initiative at the time, was at the 4th Wadham Pan American Regional Conference in Leesburg, Virginia in 2012. That was followed by joining the FMT working group, and we met in Madrid, Spain in 2012. And I sort of, being here this week, sort of reflect on that was probably the precursor to this meeting, but I think that meeting had about 12 people there. So it's really been exciting and wonderful to see how much this has grown through the years. So we participated in the working group, and through the years we've offered financial support both directly to WHO and to our implementing partners, especially during a response. Many of our partners are in various stages of the certification process. Some are certified and some are moving their way through the certification process. We've also offered technical support as members of the FMT and then EMT working group, and provided some assistance with review and editing of the blue and red books. Whoops, I went the wrong way. All right. More recently, and I think more exciting in a lot of ways, is that since 2019, USAID and the Bureau of Humanitarian Assistance has provided the World Health Organization with about $2 million in funding for work in 5 countries in the Pacific to develop, train, and expand their capacity to deploy EMTs. This approach reflects USAID's priorities to support local first responders and to support the Pacific's goal of enabling Pacific disaster response surge support. This support includes developing policies and procedures for national EMT deployment and for requesting and tasking international EMTs. USAID BHA has supported WHO in training and equipment for national EMTs in the 5 focus countries in coordination with national ministries and the departments of health, and in strengthening regional EMT expertise, governance, and response coordination. The training has included instruction with presentations, practical exercises, as well as simulations and drills to provide hands-on experience for the EMTs. Regular collaboration with peer EMTs in simulations serves to enhance interoperability, collaboration, and coordination. Equipment and supplies caches have been procured and delivered to EMTs in each of the 5 focus countries and accompanied by training in logistics and warehousing. Kiribati, Palau, Tuvalu, and RMI have each established 1 national EMT, while Micronesia has established 1 national and 4 subnational teams as part of this program. And as of last month, October 2024, 2 subnational teams in Micronesia, as well as teams from RMI and Palau, are ready to deploy. So I think in this way, our role in disaster risk reduction and health system strengthening has really helped these countries start and sustain their EMTs. Thank you.
Thank you very, very much. I have many questions, and maybe now we will ask the audience for their questions. I believe we have microphones there. So if anybody wants to ask questions or make comments or give us any additional brilliant ideas of financing EMTs, please make your way to the microphones. In the meantime, to get the ball rolling, as they say, I will have some questions for my panel members. So starting with Dr. Nahom, you mentioned resource mobilization strategy and joint funding with other programs and partners. So I would like you to elaborate on that a little bit about partnering with other health programs for increased financing of your activities. Mr. Diego, your model is unlike anything I've seen, except it looks very much like a primary health care approach, reaching out to very distant communities. How does this dual function? Your EMTs apparently has a dual function. In peacetime, you actually deliver normal, regular public health services, and when there's an emergency, you respond. Or maybe they actually do both at the same time, because we saw a lot of gunshot wounds and machete injuries, etc. How do you use this dual capacity to mobilize funds? Is it a challenge, or is it an opportunity more for your teams? So I have other questions for the other panel members also. Dr. Bernadette, you mentioned, you started your presentation with presenting your legislative background, and I understand that you have a lot of government funding for your EMTs. Does that preclude you from reaching out to more other finances? How does that give you, is that something that you are comfortable with, does it give you like a guarantee in looking forward in your activities because you don't have to run after funds from outside? Or does it put you more in the like throes of bureaucracy and you have to fight for every penny? James and David, you brought different perspectives, of course, from a partner perspective. So James, you are talking about 2.5 million to WHO WebPro, and you emphasized enabling, David also, you emphasized enabling responses to own emergencies. So this is, I understand, it's a global world, and if everybody is capable of taking care of their own homes, then they will be able to help others. I guess that's sort of the philosophy behind. I want to ask you why you choose to work with WHO. I'm grateful for that, but what is your impetus in actually working with WHO in these activities? And I hope that I have given enough time for the audience to note down some questions or comments. You may wish to answer, respond, or reflect on my questions also. I really want a little bit of discussion. I'm trying to make time for you. So let me go to my panelists now. In the same order, if you can, please use your microphones.
Thank you. So with regards to joint funding, to elaborate on the example I mentioned earlier. So recently, for example, together with WHO, there was a call for a pandemic fund. So the Ethiopian Public Health Institute, where the EMT is based in, we submitted a proposal in an effort to strengthen the national preparedness and EMT as part of that bigger package. So we secured around $100 million for 5 years project. So which includes the capacity building activity, the procurement of equipment, warehouse construction. So as that bigger package, we made sure that the EMT activity is included in the pandemic fund activity. So for the next 5 years, we have a budget to cascade the capacity building activities to the sub-national level, build warehouses in strategical selected locations, roster management system building, so such modalities we are using. So this is one of the best examples I can mention when it comes to joint funding. So,
thank you. You also mentioned transparency, accountability, and M&E, monitoring and evaluation. How important are those aspects in continuous financing?
Yes, when it comes to securing continuous funding, we need to show, have a transparent like auditing mechanism. So when it comes to that, we are, besides strengthening the government existing financial structure, we closely work with partners who has good reputation when it comes to strong monitoring and evaluation mechanism. So for that purpose, for example, that's why we are submitting proposals with WHO, whose organizations who have good reputation on that aspect. So we are still working on strengthening, creating a transparent financial mechanism, auditing mechanism, but still using those with a good reputation.
Thank you. Maybe here I want to emphasize one thing. I understand, I spoke to one of a very smart lady who was doing her PhD on evaluating EMT deployments. And she told me that there isn't a robust evaluation scheme of EMT deployments yet. And that she mentioned both quantitative and qualitative evaluations are necessary for that. So I don't know anything about that. This is one conversation. But if this is the case, I think this is something that we have to do because every deployment costs a lot of, money and resources, etc. So as part of what you're saying, M&E, I think deployment evaluations are also very important. May I move over to James, maybe?
Ooh, this one here?
Yes.
Fantastic. You're right, this is an initiative, bring this a little bit closer. It is an initiative by the New Zealand government to enable and increase domestic capacity to respond to emergencies, but also regionally increase that capacity to respond to larger emergencies in the region. You asked why we have decided to work with the WHO in particular, and I think it's that regional ability to build that capacity and really provides for expertise and is a mechanism for sharing that expertise from NZMAT, OSMAT, and others accredited through the initiative also. So a great platform.
Thank you.
And I would agree with all of that and add that from a USAID perspective, they've been supportive of the initiative since the beginning. And so I think that it's, WHO is a natural partner to do this. And so I think that that's just represents a continuation of longstanding support. I would, in terms of regional choice, some of that I think reflects USAID priorities, but also if you sort of look at our disaster risk reduction and capacity building and health system strengthening, a lot of that does happen in the region, in the Pacific, and some in Asia. So I think from a regional perspective, that was probably why that was prioritized. But in terms of WHO being the partner, I think that's just a natural choice.
Thank you. I think it was fishing for compliments a little bit on my behalf, but thank you very much. Just for other countries who might be wondering how they can reach these finances, is it through WHO or other partners, or can countries contact you directly? Both of you, please, since you are holding the money.
Yes, so this is directly channeled through the WHO's Western Pacific Regional Office. So not to New Zealand directly, but through the WHO's WIPRO as a platform. So.
Thank you.
And yeah, from our perspective, I think it's a little bit of both. Some of the funding, the funding that I discussed goes to WHO. So it would be through our regional offices, but I think in this case, it's money that's given to WHO with the intent to then support the EMTs.
Thank you very much. From my experience, we haven't worked in Azerbaijan with New Zealand, of course, but we have worked with USAID. And what I saw was if the USAID local office sees your performance, they actually can mobilize funds directly for the country also. So that happened to us, and we are very, very grateful for that. Okay, Dr. Bernadette, please.
Hello. Yeah, to answer your question about the different sources, of course, there will be some challenges and also issues of concerns that even though we have a lot of sources, there are, of course, we have priority areas. It's not only the emergency medical teams that we are providing fund, but we also have other preparedness projects that we have to fund into. It's like a give and take. We need to prioritize. Since I've started my presentation with the risk of the country, we really need to invest on the emergency medical response team. And then I talk about the quick response fund. Although this is a $10 million yearly fund that being allotted by the government to us, but there are triggers on when to use it. So it will just be used during the response and rehabilitation phase of any event. So we cannot use it during preparedness, like buying for equipment, doing the capacity building. So all of those, the preparedness stage or preparedness phase will be coming from the General Appropriation Act or fund that we will be sub-allotting to the teams, and also from the investment coming from the health facilities wherein our PMAT is stationed into.
Thank you. So what I'm hearing you say is because you can use multiple financing options from within the government budget, And sometimes they are based on the functions like MHPSS. Sometimes they are based on the process of training or things like that. So it's really about being a little bit innovative and maybe seeking deep into the government budget and making government partners to allocate more resources. Am I interpreting you correctly?
Yeah, that is correct. That is correct.
Okay. I'm trying to get my headset because I want to understand.
Aló, ok. ¿Lista?
Yes.
Ok. Bueno, en referencia a nuestro modelo de atención, el EMT y el barco hospital, en realidad nosotros sí llevamos 17 años operando ese tipo de EMT, atención primaria en salud, que es lo que hacemos, pero trabajamos en zonas de conflicto, o sea que prácticamente cada misión afrontamos emergencias. Entonces, por eso prácticamente es una experiencia ya de 17 años con este EMT y el nuevo EMT que acabamos de certificar es para casos de emergencias y desastres, que es el móvil. Pero creo que la experiencia la tenemos y sobre todo hemos dado un gran soporte a la comunidad y a la zona donde operamos. Bueno, no sé si con esto cumplo tu pregunta y lo que me estás preguntando.
Yes, very much. Thank you. I didn't, forgive my ignorance, I wasn't aware that that area was actually a conflict area. I wasn't aware that the area in which you serve is a conflict area. So it is really a dual function of both providing health care and emergency care to the people. You mentioned crowdfunding. Can you say anything about that? Crowdfunding, I think it was you. Yes, you funding, crowdfunding as a means of finance, and you also mentioned funding, receiving funding for training to other institutions. So it's like a service that you provide for other people, and in return you get paid. Is that what it was?
Sí, nosotros... sí, así es. Nosotros estamos incursionando en el crowdfunding, en las plataformas digitales para la consecución de recursos. Creo que es las nuevas tendencias de las ONGs para poder, primero, proyectarse y segundo, para recoger o recaudar fondos. Y la idea es esa, también a través de esos crowdfunding poder hacer alianzas con otras instituciones y con otros benefactores que puedan suplir y que puedan dar ese tipo de actividades a nosotros. Nosotros tenemos un gran socio estratégico que es la Unión Europea, como lo decía anteriormente, pero se me quedaron atrás muchos más, como es también Naciones Unidas a través de ACNUR y también lo que es la OPS PAHO para América Latina, que nos está dotando como su grupo de tarea, su fuerza de tarea para atención de emergencias en el territorio.
Yes, thank you. Thank you very much for these insights. Okay, wonderful. We have two brave gentlemen waiting for questions or comments. Please introduce yourself first.
Thanks, Chair. And I have to declare a conflict of interest. My name is Sean Casey. I work for WHO in the Western Pacific Regional Office, and I help to plan part of this session. But I think there are some really important takeaways from the reflections of the panelists. The first is almost every country that's been discussed is lower income, middle income, and despite that, they have managed to establish teams. Some of them are very small, some of the Pacific Island countries that have been discussed. One of the countries supported by USAID has 10,000 people, one has 20,000 people. So I think it's really important to recognize that any country can do this. Any country can establish an emergency medical team for national response. It may need support to do that, but it's an investment, and I think that's what USAID and New Zealand have reflected. It's an investment that donors should be thinking about and can be thinking about that may actually save money and save lives in the long term because it's faster, localized response, national response, and deploying an international EMT costs probably almost about as much as it costs to procure cache and provide training to national EMTs. So there's a solid return on investment case there. The second reflection is particularly about PMAT and the Philippines. Just over 10 years ago, PMAT was a country that received over 100 EMTs from around the world for a response. And now, 10 years later, they've transitioned, still as a lower middle income country, but from a recipient of a significant amount of international assistance to a country that's not only responding independently, but also now projecting that support externally. So they deployed to Turkey last year. And I think that's just an amazing narrative that not only that they've gone from recipient to provider of assistance, but they've done that as a lower middle income country. It's a growing economy, it's an emerging economy, but that they've managed to do that. And I think Dr. Velasco's reflections and also Dr. Nahom of pulling together resources from different sources. That's the key takeaway for countries. Some of that can be donor funding, some of it is government funding, some of it is funding that becomes available when an emergency happens, kind of capitalizing on that opportunity. But that patchwork is what makes it work, and it takes leadership like Dr. Nahom and Dr. Velasco to speak to those partner agencies, to the donors, to other government ministries to bring all of that together. So I think just really well done, and I hope other countries look at your example and other donors consider this investment and the return on investment for people at home and around the world. Thanks.
Thank you so much, Sean. Sean is actually the person who made this happen. So yeah, thank you so much for putting this wonderful panel together. Yes, sir. Now we have two gentlemen in the back afterwards. Please continue.
Good morning. I'm Juan Escalada from SAMU, Spain. We are a small NGO. My question goes to Dr. David Towns. I was aware of the work that USAID has been doing for the Americas. I was surprised in this panel to see that you're in the Pacific as well, and not only that, you've been supporting Azerbaijan. We've been hearing a lot about countries, but is there a place and an opportunity for NGOs to apply for your bureau's funding? Because some of organizations are not even considering it. But in our case, we've been in the process, I'm almost ashamed to say, since 2017. And it is because for a small organization like ours, raising pretty much $500,000 to get a proper EMT1 is very hard. And anything arouses, like in Valencia now, well, my team went there. Well, guess where my budget for this year is going? You know, so can we knock on your door?
So as a health advisor, I don't know all the ins and outs of the financing, but in general, the financing to develop and sustain EMTs tends to be more regional because that's viewed as, just as Sean eloquently said, that's health system strengthening and capacity building that I think long-term is obviously in everybody's best interest and is life-saving. In terms of the NGOs that we support, we tend to support them as implementing partners during a response, but we have not traditionally supported the financial requirements for going through the certification process. So an NGO would be more likely to get funding as an implementing partner, and I can talk to you separately, but there are guidelines for proposals and submission, and it's a fairly, most of our partners are large international NGOs because there is a pretty extensive auditing and vetting process, as you can imagine, to get US funding, and it sort of depends on the size of your organization, but we have not traditionally just taken applications and funded teams to go through the process. So for an NGO, as an implementing partner, that would probably be the way to get funding, but that would be to actually engage in a response and provide direct health services rather than going through the process. And that may change, or there may be exceptions, because I tend to work on the implementing partner side rather than the funding side that we do in the Pacific. That's really through our regional office and through a grant to WHO. So, but I think that's basically sort of how it would come out. We don't have a direct process where you can say we need X dollars to go through the certification process.
Thank you very much. I would suggest you to talk to partners, really, because partnerships always creates miracles, even when it seems like there is no hope of funding. Yes, please, thank you. Introduce yourself first.
I'm Dr. Adolphus Iya. I'm from a small country in West Africa, Liberia, and I work with the Ministry of Health. I've been involved with responding to disasters like the Ebola virus disease of 2014 and the COVID. And here I am in this conference. We do not have a standard EMT as will be envisaged by the 2030 strategies or initiatives. So we're looking forward to establishing one from this conference. So first of all, I want to say thanks to the panelists for their insightful contribution. My question would be a request to give us who are looking forward to starting an EMT, many of the countries in the African region are looking forward to starting one. So I think we have a pioneer in Ethiopia, but other panelists also can make a contribution to this request. What would be an initial target for funding source? I know there are multiple funding sources that we could potentially look to for funding EMTs, but what would be your advice for initial target for funding sources when we talk about establishing and deploying EMTs for those of us that are thinking of starting one, so that we cannot spend a lot of time repeating some of the hurdles that you went through in establishing yours?
Thank you. How does Liberia get started? Well, if we don't, before we get any answers, I would suggest, as part of WHO, to contact AFRO, of course, first of all. That would be the easiest, because they know how to get started. But do we have any suggestions? Ethiopia, the country of my Director General.
Thank you. So to say a few things about the evolution of Ethiopian EMT. So 6 years back, there were conflicts here and there. Following that, there were humanitarian emergencies. So there was a need to organize medical professionals and send them to respond for those emergencies. So it was done without any preparation. It was we immediately went into response phase. So we learned from our mistakes, and we were searching for solutions. And we just discovered there is an initiative that's called EMT. So we found it to be our solution. So it needed advocacy within the system to familiarize the higher leadership, authorities, the stakeholders, why we need to invest in this area, because we were advocating using our own wrongdoings, our mistakes. So if this was present, we could have saved this much life. If this was present, we could have responded quickly than we responded. So we used our own experience to highlight the need for EMT. So there were different names within the system. So we didn't want to create any conflict of interest, so we just focused on this is a network. We just want to introduce the standardization, then go on to setting up the teams. Then there is also existing strengths. For example, in our country, there is an existing rapid response team, which was more focused into detection, surveillance, the laboratory. So we needed to, there was a need to create a collaboration with that existing. So we are not starting from scratch. So the RRTs will detect, will conduct the surveillance, will conduct the laboratory investigation. Then when it comes to case management, the EMT comes in. So it's a continuous process. So by highlighting those progresses, we reached to where we are today. But still we have
Wonderful.
long ways to go.
Thank you so much. And I want to add, really, if you reach out to AFRO, you can have a more detailed experience sharing with countries like Ethiopia, Senegal, who got recently certified. So we are good at WHO in bringing people together so that they learn from each other. So I would recommend that you reach out to AFRO colleagues. They, if they are not here, you can go to the WHO booth, EMT booth, and just ask for an email address. Yes, madam, please.
Thank you. I'm Dr. Bichwarelo, public health physician with Ministry of Health, Botswana, and EMT lead. I would like to thank the panelists for the information because this is really important for us who are trying to establish EMTs. Special thanks to Dr. Nahom. Your pooling of resources is quite informative. I would like to touch base with your team to find out how it's pooled and how it's spent, especially for deployments, or how it's spent and monitored when it's coming from different sources. For government, for donations, where is it managed at? That would be very interesting. I would like to also point out to the USAID Bureau for Humanitarian Response to say, I heard your earlier comment to say you are not truly intricate into the response of financial ways of USAID. I was going to tap onto that to say, in Botswana, we trained basic emergency care training and one induction through USAID, funding to WHO. So I wanted to hear, because we went back to say, could you assist us again to do another training? And it was not clear how that was coming about. So I wanted to hear maybe a clear answer to say, what is the link? Where do we go directly from here as Botswana EMT to tap into the funding? But maybe you can provide a feedback of saying, I'll look into that so that you can come back to us and we know. I'm thankful that you are doing this through WHO so we can still reach to our country office and find out how we can get further assistance. I would like to thank you again.
Thank you very much.
I apologize for the lack of clarity. And being on the other side, it's not that much more clear, to be honest. I think going to the WHO regional office, and even from an USAID standpoint, a lot of the trainings and supportive programs like that are funded through our local offices. The side of BHA I work on is really the implementing partners during a response. So I think that just like your advice to the previous person, I think going through the WHO office, because a lot of the funding will be that way, and there may be direct funding, but that would be through our regional office area.
Thank you. Yes, please.
Thank you very much, Dr. Herbosa from the Philippines. I stood up because I'm in the governing board of the Pandemic Fund, a fund created by WHO and the World Bank. And it was mentioned by one of the panelists. We just finished a round. I sit in the board, and we just representing the low middle income countries and of the Western Pacific. And we just had a round of $500 million that were given to 3 countries in the Western Pacific, Fiji, Samoa, and the Philippines. There's another set of funds that were also given to the Afro region. Afro region actually got a top of the fund from the MPOX support or response. So I think there are several other funds available to countries that should be known. So the pandemic fund will have a second round. They are able to raise funds from rich countries that donate to the fund. And you just have to understand the purpose of the fund. Maybe the next time you organize something like this, you should invite the banks, because middle-income countries are not, we're not recipient of grants anymore. We have to do soft loans. So I've taken loans from the Asian Development Bank. There's also the CIIB. So the bankers should actually be sitting in a room like this as well to be able to inform the others what the sources of funds are. There's the Health for Life Fund, also by the UN and UNICEF, and they're creating funds for NCDs and mental health, which is what we need in MPHSSS. So probably that can also be tapped. So the sources are out there. And then there's also increased investment rounds because of climate change. There's the Green Climate Fund, and most recently, the Philippines became the recipient for managing and governing the Loss and Damage Fund, which is basically for the countries most affected for climate change. So those are many sources that are available. They're all new, and this country should learn how these funds are being distributed and how you can tap that one. And also, I'd like to say the USAID has been the biggest contributor to the Philippines for over the years in terms of Disaster Office of Foreign Disaster Assistance and all these systems resiliency development projects. Thank you.
Thank you so much for this general overview of and indicating the new available funding. Maybe WHO can take a homework from here to identify the possible financing mechanisms. But I really want to emphasize the importance of having some money aside for EMTs from the regular budget. That gives stability and credibility and an opportunity to look forward into the future with a little bit more security in terms of existence. But I think we have to look for additional funding. There is apparently funding, as I just mentioned, new funding about climate. You know, I'm a primary healthcare advocate, and I can get money for primary healthcare from any funding source. It ties very well to anything, and emergency response is very similar to that. So I think we can get creative, we can get applied to new funding sources, we can find ways to reach people through crowdsourcing. We can try to see if we can find money for specific functions like MHPSS or reproductive health. But maybe WHO can actually write very practical guidance on that to see what are the options that countries can access to. I want to ask my panelists if they have any last words for this panel before they leave. If not, I really thank you all very much, and you all very much for your active contributions. This has been a wonderful session. Thank you.